Hello everyone, this is Dr. Matsuno. In the program, I teach medical students. Today we are going to touch upon acute pulmonary embolism. It's one of the pulmonary emergencies, a commonly encountered disorder with variable presentation, making it a challenge for the diagnosis. The delay in the management of pulmonary embolism is associated with the poor outcome and high degree of mortality and morbidity. We are going to touch on this topic with regard to in relation to its clinical types, etiology, pathophysiology, clinical presentation, and management. So this picture is the CT chest, showing a clot in the pulmonary artery. Pulmonary embolism is obstruction to blood flow. The pulmonary artery or its branches due to the thrombus elsewhere in the body, most commonly in the deep venous thrombosis, most probably in the lower extremities. Pulmonary embolism can occur by embolization of material other than thrombus, like air, fat, tumor cells. Okay. They originate somewhere else in the body and they reach the pulmonary circulation through embolization. Most commonly, PE is due to deep venous thrombus. Okay. As I told you, the spectrum of deep venous thrombosis with pulmonary embolism is described under the term venous thromboembolism. Well, as such, pulmonary embolism is a very common disorder with the most variable clinical presentation, making the early diagnosis challenging. That is the reason why there is a high rate of morbidity and mortality. Coming to etiology, the most common cause of pulmonary embolism is deep venous thrombus. Okay. The risk factors for the deep venous thrombosis, as described in the Bricos trial. Okay. They are hypercoagulability, stasis, and endothelial injury. These risk factors are similar to that results in the pulmonary embolism. Okay. The other risk factors include genetic and acquired. Genetic factors are conditions associated with thrombophilia, protein C deficiency, protein S deficiency, and genetic hyperhomocystinosis. Well, acquired conditions are plenty. Prolonged blood rest, following orthopedic surgery, hip surgery, or knee surgery. Okay. Travel for more than 4 hours, either by air, bus, or car. Well, bed rest more than 3 days following the surgery. Indwelling in venous catheters, obesity, pregnancy, consumption of oral contraceptives. Malignancy is one of the most common risk factors for the pulmonary embolism, and chronic smoking. These are some of the risk factors to mention for the deep venous thrombosis. And subsequently, the cause for pulmonary embolism. This is the CT chest with the pulmonary embolism. This is the X-ray chest showing the presence of atelectasis in the bases. Coming to types of pulmonary embolism. So earlier that was described as the massive or large pulmonary embolism. It is now replaced by the pulmonary embolism with hemodynamically unstable status. That is hemodynamically unstable pulmonary embolism and hemodynamically stable pulmonary embolism. Hemodynamically unstable pulmonary pulmonary embolism is associated with systolic blood pressure less than 90 mmHg and a sudden fall in systolic pressure more than 40 mmHg. This is associated with the high rate of mortality. Unless treated early, the patient is going to die. Because of obstructive shock and right ventricular failure. Hemodynamically stable PE may be small or moderate in size, presents with spectrum of clinical features. Okay. But blood pressure is normal. These clinical features of hemodynamically stable pulmonary embolism, which are relatively small and moderate in size, they are non-specific. Maybe associated with fever, sometimes chest pain and breathlessness, cough with expectoration, etc. And the detailed discussion of the clinical manifestations we are going to talk about the clinical presentation. Coming to the epidemiology, there is increased prevalence of the pulmonary embolism, rating to 53 to 162 for 1 lakh population who may suffer with the pulmonary embolism in the United States. Estimated mortality in the developed countries accounts for 100,000 people die of pulmonary embolism every year. It's very high. Coming to pathophysiology. Well, pulmonary embolism occurs when the thrombus elsewhere breaks off and enters the pulmonary circulation, causing obliteration of blood flow in the pulmonary artery or its branches. Okay, it could be peripheral or central embolism. Pulmonary embolism is usually multiple, bilateral, commonly involves the lower lobes. Either it could be central, involving the main pulmonary artery, or it could be peripheral, involving the branches of the pulmonary artery. Well, large central embolism causes obstruction to pulmonary blood flow, resulting in the deleterious effect on the circulatory system. Okay. That results in the acute right ventricular failure, resulting in the peripheral circulatory failure and shock, secondary to obstructive shock. Well, in a small emboli, results in pulmonary infarction, resulting in hypoxia due to ventilatory perfusion mismatch. What's happening? The alveolar open and the ventilation is normal. The alveolar sacs are normally ventilated and the capillary blood flow is dramatically decreased. So there is increased dead space ventilation, resulting in hypoxia. Okay. The hypoxia leads to the deleterious effects, resulting in the stimulation of the respiratory center. There will be increased respiratory rate, carbon dioxide drive out. That results in the respiratory alkalosis. Okay. In these situations, when you do the ABC, there is PCO2 is low and there is pH is elevated, indicating respiratory alkalosis. But the red flag signs of pulmonary embolism includes increasing PCO2 with increasing hypoxia and respiratory acidosis, which indicates impending respiratory failure due to obstructive shock. That is, there is impending obstructive shock secondary to the total failure of the pulmonary circulation, thereby resulting in the pulmonary or respiratory failure. There is elevated PCO2 in ABGs is an indicator of impending respiratory failure and obstructive shock. So these things have to be kept in mind. There is impaired gasosuction as airflow into the alveoli is normal, but embolism normally ventilated. Okay, but there is the alveoli are normally ventilated, but the blood flow is disrupted. So the capillaries are not filled with blood. So there is ventilation perfusion mismatch resulting in hypoxia. Well, there is increasing pulmonary vascular resistance because of the release of serotonin and other mediators that results in the pulmonary vasoconstriction. And hypoxia also triggers the pulmonary vasoconstriction, thereby resulting in the raising pulmonary vascular resistance. That again causes the afterload onto the left ventricle, onto the right ventricle. That goes into the right ventricular, results in the right ventricular dysfunction. Then right ventricular failure. Well, when there is a progressive right ventricular failure, there is pushing up a anterior shift of the interventricular septum. That results in a sort of reduced filling of the left ventricle. So left ventricular stroke volume is reduced, and that results in the peripheral septal failure. Okay. So massive pulmonary embolism is cause for cardiac arrest. Okay. Peripheral circulatory failure, cardiac arrest. So at times, even in the large size pulmonary embolism, the individuals are sometimes asymptomatic. They are diagnosed, they are found to have the pulmonary embolism while they are working, some laboratory workup is going on them for different conditions. That is incidental finding in certain of the patients with large pulmonary embolism. It's not always like that. So that's why the spectrum of the presentation of pulmonary embolism is variable. So that is the reason for delayed diagnosis and high rate of mortality related to pulmonary embolism. So we must be cautious about the presence of risk factors and the clinical presentation with the features of pulmonary embolism, which we are going to talk in the clinical presentation. Okay. By and large, in the central pulmonary embolism, it is the right ventricular dysfunction associated with the right ventricular branch block, ultimately resulting in the left ventricular failure and the circulatory failure. So that is associated with the high degree of mortality in pulmonary embolism. So this picture shows the signs and symptoms of pulmonary embolism. So a picture representation. Presents with shortness of breath, rapid breathing, chest pain, rapid heart rate, lightheadedness as if passing out, coughing up blood, that is hemoptysis. So with these symptoms, you should have the suspicion and consider the unexplained chest pain as the cause of pulmonary embolism. Coming to the clinical presentation. Well, pulmonary embolism is such a difficult situation because of the variable clinical presentation. As I told you, at times patients with a large PE are asymptomatic, identified incidentally during workup for another condition. So it's surprising. More than 30% of untreated patients die, mainly due to delay in treatment. Okay. Well, common presentation is dyspnea, chest pain, cough, hemoptysis, syncopal attacks. Yes. When you examine, there is raised JVP with hypotension. Okay. Dyspnea indicates presence of progressively increasing hypoxemia. Chest pain is because of the peripheral infarct causing pleurisy and irritation of the pleural membranes. Cough and hemoptysis secondary to the intrapulmonary bleed. Syncope indicative of the hypotension and peripheral circulatory failure. When you examine the extremities, for the presence of the deep venous thrombosis, there could be pain and swelling and redness of the cough muscles. So, clinically, cardiovascular system examination shows presence of tachycardia, tachypnea, right ventricular gallop, signs of pulmonary hypertension in the form of loud P2, parasternal heave, raised JVP with hypotension is the important finding in the patients with pulmonary embolism. Cool peripheries and cyanosis indicative of impending shock. Pulmonary embolism is one of the causes of sudden cardiac arrest and death. Because some of the patients with the pulmonary embolism, they may present with cardiac arrhythmias, atrial fibrillation resulting in cardiac arrest. Well, having encountered the patient with hypochemical presentations and the history, proceed with the rapid evaluation. Take the ABGs. ABGs will show presence of hypoxemia. Well, hypoxemia in the presence of normal X-ray chest is diagnostic of pulmonary embolism. Okay. There is hypocapnia is associated with respiratory alkalosis. As I told you earlier, because of the increased respiratory drive, there is a drive of carbon dioxide, thereby resulting in hypocapnia and respiratory alkalosis. Presence of hypercapnia with respiratory acidosis is the red flag sign of respiratory failure and obstructive shock. Then, brain natriuretic peptide, BNP, it is elevated, indicating right ventricular dilatation and stage of the right ventricular myocardium and myocardial dysfunction. Troponin is elevated, indicating of right ventricular ischemia. D-dimers are indicative of the coagulopathy and lysis of the clot material. ECG. ECG is taken in order to assess the presence of arrhythmias and ischemic changes. X-ray chest shows some signs of atelectasis at least. CT pulmonary angiography is the gold standard for the diagnosis of pulmonary embolism. Besides, they do lung scintigraphy, and if these two are not available, pulmonary angiography is the earlier diagnostic workup done on the patients with pulmonary embolism. Magnetic resonance angiography is not that sensitive in the diagnosis of pulmonary embolism. Echocardiography will speak about the presence of ventricular dysfunction. Well, the compression ultrasonography is nowadays done in certain centers to find out the lung pathology in cases of pulmonary embolism, which are complicated by some degree of infarcts and atelectasis. This is the brief account and the evaluation of the patient with pulmonary embolism. This is the X-ray test of the patient with pulmonary embolism. And coming to the treatment, I'm going to touch one of the outlines of the treatment. It is the duty of the interventional pulmonologist to manage the pulmonary patients with pulmonary embolism effectively in order to reduce the mortality. The initial treatment includes for a patient with the unstable hemodynamic status. Number one is the supportive care. Number two, anticoagulation therapy. Number three is measures to reperfusion methods. And the next step is the chronic treatment of the patient, chronic treatment of the pulmonary embolism with anticoagulants. Initial treatment includes supportive care to make the circulatory status, to stabilize the circulatory status. Give oxygen therapy to prevent hypoxemia, either direct mask oxygen or ventilator support. Ventilator support should be non-invasive. Invasive ventilator support, everybody knows that there is certain amounts of complications related to the on the peripheral circulation. That is, invasive ventilator support is associated with the circulatory dysfunction. So these things should be kept in mind when the patient is put on the ventilator support. Well, IV fluids should be given cautiously because IV fluid administration is going to overload the right ventricle, thereby aggravating the right ventricular dysfunction. Vasopressin is the right drug to combat hypertension. ECMO is the right choice for the patients with persisting hypoxemia with circulatory failure, the patient with pulmonary embolism with unstable hemodynamic status. Okay. These are the initial steps of management of the patient with hemodynamically unstable pulmonary embolism. The second step is anticoagulant therapy. Anticoagulant therapy is the mainstay of the management. After stabilizing the patient, even before that, when you suspect the patient is going to land in circulatory failure, start the anticoagulant therapy right away. So low molecular weight heparin is the drug of choice, commonly used in many centers. Okay. Well, that is followed by reperfusion measures in order to open the pulmonary arteries where the pulmonary blood is obliterated. Thrombolysis should be cautiously given, okay, taking care of for the excessive bleeding. So if the patient had suffered earlier stroke, the indication of thrombolytic treatment is rather top. Better not to give thrombolytic treatment if there is increased tendency of the patients with bleeding, especially cerebral hemorrhage. So benefit of thrombolytic treatment should be weighed or balanced with the bleeding tendencies with regard to the patient. It should be patient-based, individual-based. The better one is the catheter-directed removal of the clot. So that is one. The surgical embolectomy is the another method of removing the thrombus in the pulmonary artery. This is followed by the chronic treatment. Chronic treatment is given in order to prevent recurrence. Well, the recurrent pulmonary embolism, the major cause is failure of following chronic treatment. But it is very difficult to decide whether to go for the chronic anticoagulant therapy or not. This should be based upon the individual based upon the individual choice, depending upon the condition. But if the patient has got increasing tendency for the bleeding, it should be weighed against the benefit of anticoagulant therapy. So when the patient is on anticoagulant therapy, he should be monitored with regard to prothrombin time and INR. So usual period of anticoagulant therapy following initial stabilization is for about 3 months with regular laboratory follow-up. Whether to continue the anticoagulant therapy or whether you have to decide on the extended anticoagulant therapy or not depends upon the individual basis. Okay. That has to be decided by the attending pulmonologist. So what is the differential diagnosis? So there are so many conditions that may make pulmonary embolism. So it could be acute myocardial infarction, acute coronary syndrome, it could be arrhythmias, it could be acute pericarditis, acute pancreatitis, pneumonitis, or pneumothorax. So these are some of the conditions from which we have to differentiate the patient with pulmonary embolism. Coming to the prognosis. The factors that determine the prognosis are delayed treatment of large PE. So it is usually the clinician encounters for the early diagnosis of pulmonary embolism because of its variability with regard to its presentation. So delay in the treatment of the large PE is going to end up in fatality. Pulmonary embolism associated with the deep venous thrombosis is again guarded prognosis. And pulmonary embolism severity index score. There is scoring system is used with basic putting the score with less than 65 as a class 1, 65 to 85 class 2, 85 to 105 is class 3, 105, 120 is class 4, and beyond 125 is class 5. So basic class beyond 4 and 5 is associated with high degree of mortality. Well, this is the brief account on the patient with acute pulmonary embolism. Well, my dear students, please remember this pulmonary emergency, pulmonary embolism, a common situation encountered by the pulmonologists. It is a clinical emergency, but with variable presentation, making the diagnosis a challenge. This challenging situation should be identified early and treated early in order to prevent the mortality. Hope, my dear students, you like this video. Okay, please watch this video in order to improve your clinical acumen and deal with the patients effectively in order to reduce the mortality associated with pulmonary embolism. Thank you once again for patient listening. See you again in the next time. Till that time, bye-bye.